doulas and birth workers everywhere. I'm excited today to be going over some really interesting news that I came across, and I'm going to geek out a little bit as the birth nerd that I am on some data. So I know some of you love evidence and research, and a new study comes out and you love like digging into it. And some of you are like, oh, study, I don't even know what that all those words mean and all those things mean. And I don't think you need to love research and love reading studies to be a good doula. But I think we need to be able to keep up to date on the research that's out there. So today, we're going to dive into something really, really interesting. So as many of you know, I am from the Toronto area in Ontario, Canada. And in Ontario, we have this really cool thing called Born Ontario. So Born stands for the Better Outcomes Registry Network. Right? And basically it's the network that all hospital systems send their data to. So all the birth statistics, all the birth outcomes. And there is some really, really cool stuff that Born Ontario produces in terms of publications. Okay, so if you're interested in looking at some of their publications, head on over to bornontario.ca. So they sent an email out a couple weeks ago, and they've got a couple of sessions that one was taking place yesterday, and there's another one taking place next week around updated guidelines for oxytocin use in labor. Now, I don't know about you, I don't always love using the word oxytocin when what we're really talking about is pitocin. We're talking about a synthetic version of oxytocin. Oxytocin, of course, is the hormone that we produce in labor that makes us have contractions and does a whole bunch of other really, really cool things, but is, of course, the primary hormone responsible for labor. And we know that lots and lots of people are induced. About a third of people are induced in Ontario. You should know what that statistic is like in your area. But one of the things I think we can all probably agree on is we're seeing a lot of inductions happen. And if you've been working as a doula for any amount of time, you probably know that inductions for our clients, in terms of their experience, in terms of our experience supporting them, it often doesn't go how people had hoped, does it? You know, it's one of those things that just kind of falls short often in terms of the experience people were after. I can say, as someone who's been doing doula work for 20 years, I've attended an awful lot of inductions, and I don't like them. They are not fun as a doula, right? Of course, I support my clients who choose them. What I don't love is this idea and this notion that we better do this or else, because it doesn't always translate into very good experiences for people, and people have increased levels of dissatisfaction, right? Okay, so let's come back. So why are these guidelines really interesting and really important? Why am I talking about them? Because there was a lot of really, really cool recommendations coming out of these guidelines that I think have the potential to really change the experience of people in labor in Ontario. So first of all, let's talk a little bit more about Born and where this is coming from, okay? So Born Ontario, their mission, their purposes is, and I'm gonna read right from their site. In fact, you know what? I'm gonna show you their website right here. We're gonna read right through it together, okay? What is their goal? They are here to identify where certain healthcare services have not been offered or made sufficiently available to healthcare recipients to facilitate access to services, right? They're here to facilitate continuous improvement. They're here to also identify where outcomes for patients, our clients, are statistically discrepant with accepted norms. They're here to improve the quality and efficiency of care for healthcare recipients, for our clients. And look at all these other things that they're in charge of as well. Helping to provide reports so that caregivers can make good improvement, can make adjustments when necessary, right? Creating reports that help with surveillance, that help make care delivery easier and more efficient, right? Help to prevent disease or injury and promote health. So when we think about all of these things are amazing. These are amazing, amazing goals, aren't they? All right, so they released an email with these new safe administration of oxytocin guidelines. Now, this was reformatted in January, okay, but was originally done in 2019. Listen, I don't know what the 2019 one said. I'm here to talk to you about what this one says right now, because it has some really, really cool things. So let's dive in to this report. And for those of you that are newer to this kind of, really digging into a study, I am certainly not an epidemiologist. I am not a research analyst, although I did a lot of research in my previous corporate life. I'm just a doula that's been doing this for a really long time, and childbirth educator, and I want to help doulas understand the changes that are taking place. It's sometimes hard to keep up to date, isn't it? Okay, so we're going to review the brief. Now, when you go through this full study, for those of you that want to geek out on it like I like to, there's some really, really, really interesting things, but I want to show you the summary first, and then we'll dive in. And for those of you that want to geek out with me, you can stick around after I do the review of the main points, and we'll go through the study a little bit more deeply. So, best practice recommendations, okay? Shared decision-making. Well, hello, hallelujah. Shared decision-making. Patients should be provided the information on oxytocin induction, augmentation, and expectant management, okay? That they should be given an opportunity to be fully engaged in the birth planning process and supported to make informed decisions to improve their experience. And that needs to be documented in the patient's chart. All right, y'all. I've been a doula for a long time. And if you've been a doula for even a hot minute, I'm sure you're thinking, well, that's not the experience my clients get. My clients are told they have to be induced or else these bad things are going to happen. And clients often end up showing up for an induction that they don't want, that they don't feel is necessary, and then end up with outcomes that they weren't expecting, right? So I think this is a really, really interesting thing for us to now use to help our clients understand how this process should work. The number one recommendation on this list, best practice for the use of oxytocin, of synthetic oxytocin, is shared decision-making model. All right, this is an interesting one, interprofessional team communication, right? That the communication between everyone should be clear, direct, and respectful. That leadership should develop an environment where different people within this team can openly discuss the appropriateness of an oxytocin order, okay, how it's being titrated. So obviously we're getting into some medical stuff here, and its effect on the fetal heart rate, without hesitation or concern of instigating a conflict between the members of the healthcare team. Okay, what does that tell us? That tells us that if a nurse or midwife are feeling like Pitocin isn't working well for a baby, that they need to be able to say to the doctor who's in charge of that care, that client's care, we should stop this because this baby isn't doing well. That's what that's telling us. And or vice versa, of course, vice versa. A nurse that keeps upping the pit and a doctor or midwife comes in and like, oh, whoa, this is like a lot, that doesn't seem to be going well. Everyone needs to be able to speak. All right, so indications for augmentation or induction, right? That the prescriber, AKA the doctor or midwife, will utilize the appropriate indication when ordering oxytocin for induction or augmentation. That they will use sound clinical judgment and good clinical justification to determine if it's likely to improve maternal or fetal outcome. Okay. We're going to talk more about this later, but the number one thing we all hear, right? That whatever it is, someone's too old to wait. They should do it at 39 weeks because of the ARRIVE trial. Oh, the baby's going to get too big. Baby's going to get too big. We're going to see later in this document is not an indication for an induction. It is not an indication in current Canadian guidelines for an induction, okay? So it is not likely to improve maternal or fetal outcome to induce a baby for size. All right, so the professional skills and training point. So there's a few points in the middle I'm going to spend a little bit less time on because they're a little bit more medical. I want to focus more on how this is going to relate to how we can share information with our clients, okay? So the point number 4 is that any caregiver that's using or administering oxytocin, synthetic oxytocin, needs to really understand it and have specific training in it, okay? It also needs to be monitoring people appropriately, and they need to be able to be monitoring them constantly, meaning they need to be on site, okay? So for those of you that maybe are in hospitals where doctors aren't always around, there are still some hospitals that would have doctors sometimes leave the unit, that's considered not appropriate, in this case. Okay, the hospital preparedness for adverse events. So what this is telling us is that it should only be used in a hospital that has quick access to an operating room, right? They're saying here within 30 minutes in case a cesarean is needed, right? Or they have a formal process for patient care transfer. So that could be in a situation where maybe it's a rural hospital and that if they need a cesarean, maybe they need to transfer somewhere else. So this is an interesting point, right? I want you to just ask yourself that question, like, why would that be important? Okay, medication handling. So of course it needs to be stored safely, labeled properly, got to be checking the expiration dates, things like that to keep quality good. All right, so again, medical, I'm going to skip over these quickly. Standard use, number 7, each hospital, it has a standardized protocol, okay? That things that help to make sure that people aren't given the wrong dose, they're not given too much, they're not given it's not upped at the wrong intervals, things like that, right? So it says right here, it would not be appropriate to provide a verbal or remote order for oxytocin. A doctor that's off-site should not be telling a nurse to give oxytocin to somebody. They need to be there. That's what that's telling us. For those of you that live in more remote areas, that's an important thing for you to know, okay? Number 8, again, a medical thing here, independent double check and smart pump use. Okay, so it's checked twice before preparing the medication and setting the initial pump infusion rate, okay? Again, medical thing to avoid complications, right? Then number 9 is low dose regimen. So what does that mean, right? That you start really small. So that we go deeper into here. It talks about starting the dose really small, and it's increased at a specific rate. That comes back to that protocol that we talked about in that last one. But all of these things are justified in the patient's chart. Why were things done when they were done? And that brings us to number 10, which I think is something that I see a lot of doulas chatting about online, which is around stopping Pitocin. So there are times where someone's been on oxytocin, on synthetic oxytocin for a really long time, and there's just no dilation happening. What happens over time? And what have you ever heard people say about really long inductions, right? You might have heard a doctor, midwife, or nurse talk about how the uterus gets tired after a while, right? The goal of oxytocin is often to get contractions coming to 2-3 minutes apart, right? That's really a lot of contractions. And because inductions sometimes take a really long time to dilate the cervix, what can happen is that someone's uterus starts to get tired. Remember, our uterus is a muscle. Well, what happened if you did this, for 10 hours, right? You did this for 10 minutes, you'd be tired. So imagine our uterus is working so hard for so long that it can get tired. And what happens with a tired uterus when a baby's born? A baby is born and the uterus sometimes has a hard time contracting to stop bleeding, right? So it can increase our chance of hemorrhage if we have a tired uterus. And so sometimes there's a point where the body just isn't responding very well anymore to the oxytocin to create any further dilation. And sometimes the best thing to do in those cases is to stop the Pitocin, right? Stop the synthetic oxytocin, give people's bodies a break, right? Which sometimes the contractions continue and sometimes they peter out. And then to start it back up, right? So There's some instructions around here around how to manage that, when is appropriate, and all of these things. Again, medical in focus, but interesting for doulas to understand why that might happen, right? All right, now, my favorite, I hope you've stuck through with me for this long. This is my favorite one. My favorite one. I'm gonna increase this. Look at this, look at this. The number 11 recommendation is that people receiving synthetic oxytocin receive continuous one-to-one care by a nurse, that they receive advocacy and comfort measures and monitoring. Right? People who are having an induced labor need more support around advocacy and comfort measures. Okay? So, and yes, they absolutely need one-to-one nursing care. We all know we're having some staffing shortages in many hospitals right now. We have nursing shortages. And I know many hospitals are no longer doing one-to-one care. This is an important point here, that this is a strong recommendation. This is one of only 11 recommendations around this, that they need to be having one-to-one nursing care, right? Or midwife care. And they need comfort measures. They need support with comfort measures and monitoring. All right, so I'm going to dive down a little bit deeper. So for those of you, let's just stop here for now. So for those of you that are not research nerds and you're like, okay, Stephanie, thank you for that. Really great information. What do I do with that now? Well, I'm going to break down a few different posts on our Instagram account. So feel free to go there at Doula School. It's our Instagram account feed. I'd love to have you subscribe and follow us along. But I'm going to dive down a little bit deeper in thinking about what does this mean to us? And so as doulas, our role around advocacy, and this is seems so contentious often online, where we see a lot of doulas that have really suffered a lot of vicarious trauma in the system and who've seen some bad outcomes, especially with things like things that start with induction. This is not an uncommon thing. Our clients are upset, they're disappointed, there are a lot of cesareans, and doulas start to feel some discomfort. You know, as soon as our clients start to mention, oh, my doctor said I might need an induction, and you're just like, because of all of the past that we've experienced. And when we talk about advocacy, then online, I see this a lot. I was just saying how this can be contentious, where people think that advocacy somehow means that you need to tell your client an induction is a bad idea and they're going to have a horrible experience and that it's not going to be a good thing. I see doulas who do this, or doulas who post and say, like, how do I convince my client not to have an induction? That is not advocacy, and that is not your job. Our clients, we are here. If they hire us, then they care for what we have to share. They care about our ability to help them navigate this system, to help them navigate difficult choices, to help get them the information they need when they need it, not more than they need, but not less than they need. And I know that is such a balance, being able to do all of those things, being able to figure out, do I share this bit of information or not? Do they want it or not? And you know what? Here's what I found as a doula. I just ask. If my client were to say to me, hey, my doctor is suggesting they might need to schedule me for an induction, I would say, how do you feel about that? Is that what you imagined for your birth? What are the reasons that you don't want to do that? What are the reasons you do want to do that? Do you want to explore what an induction might look like and feel like? Do you want to talk about that? Do you want me to send you guidelines of when inductions are appropriate and when sometimes they're a little bit less appropriate? If the reason for your induction didn't fit the current guidelines, would you want to know that? Or do you want to just do what your doctor's telling you to do? You have a big exploration around some of those questions. And depending on where your client comes out, either you need to make peace for yourself with the fact that they're maybe going to go ahead with an induction that goes against guidelines, but they're comfortable with that and that's what they want to do. And as a doula, you need to let them have the outcome that goes with the choices they're making, right? Or the client's going to realize, whoa, I do want to know all of this. I didn't realize I didn't have to do this. Thank you, Stephanie, for telling me this and for helping me to see that I can say no, or I can just not show up to that induction or whatever the thing may be that where they decide to go. But I don't think our job is to save people from inductions, right? Listen, I don't like them as a doula. I don't like what I see when I see them. They don't look fun at all. Not fun at all compared to some of the other births that I've attended. But it's not our job to save people from their inductions, right? That's going to make you feel crappy if that's your goal, because you're going to be unsuccessful a lot of the time. And so you're going to feel that people are, your perception is that people are getting duped into doing these inductions. Induction is not a bad thing. Induction is just induction, right? Us helping people trust their instincts, listen to what feels right for them, helping them to navigate a complex system, helping them to learn information when they want it and need it. That's our job. That's our job, right? So you can share some of these points that we just went over with your clients to help them see and help them to make decisions for themselves. All right. For those of you that have had enough listening to this report, you are welcome to log off right now. For those of you that want to geek out with me a little bit more, let's dive a little bit deeper into this, because there's some really, really cool things in this document that I want to talk about. All right, so we're going to scroll down here through that. Okay, so it gives us a little bit of background and what is oxytocin, you know, how long does it last? Look, okay, I like this one, right? Your clients want to know, what are the benefits and trade-offs of oxytocin, of synthetic oxytocin? Well, here we go. It gives us contractions typically, right? Works pretty quickly. We can see here it works pretty quickly, right? The steady state achieved, usually about 40 minutes. Okay, that's pretty great. Gives someone labor in 40 minutes, right? Well, it gives us contractions. It doesn't give us labor, does it? Okay, how long until, what if we turn it off, right? We're here, half-life, the half-life. So if a baby is not doing well with oxytocin and you turn it off, that within 3 to 6 minutes, it should stop having as much impact, right? Okay, well, what are the side effects and risks? Well, let's look at all of this. That's a pretty big list, isn't it? That's a pretty big list. Cardiac dysrhythmias well, that's in maternal, but we know that can happen to the baby as well, right? Okay, did you know this one? Did you know that hyperbilirubinemia is a potential side effect of synthetic oxytocin? Interesting, right? So here's the thing where it gets really interesting to me. The misuse of oxytocin during labor remains one of the most common malpractice claims. Okay. Accounts for 45% of HUROC. HUROC is one of the insurance providers in Ontario, and 25% of CPMA liability costs. The obstetrical care is associated with approximately 46% of HUROC and 33% of CMA compensation payments. Okay, so what we can see is that obstetrics is a high area of medical malpractice issues, and oxytocin represents many of those. Okay, so why? Decreased attentiveness while using oxytocin, because we use it all the dang time and we become desensitized to its use, right? Okay, I'm adding that on. It doesn't say that in the report. I'm adding that on. Results in 33% of HUROC's cases. Okay, lack of awareness and compliance on the hospital's own oxytocin protocols accounted for 49% of obstetrical cases between 2004 and 2013. Okay. That's why this document exists, y'all, because it's causing so many liability issues, right? That kind of blew my mind a little bit. Seeing that and learning that, I thought that was really, really interesting. All right. So, well, we kind of go down. There's a lot of really interesting things here. Okay. If you're interested in the availability of induction services by level of care, we all know hospitals have a level, right? Level 1 is like your rural hospitals. They subdivide into level 1A and 1B. And level 2, A, B, and C, and then level 3. Level 3 is, your big city, high risk obstetrical units, right? So it just talks about the availability of induction depending. So you can see that only about 50% of level 1A hospitals can actually do inductions. So they probably have pretty low induction rates, right? Because, in that area, of course, those hospitals do. Probably because if someone needs to be induced, they need to send them over to a different hospital. Yeah, so that's kind of a different kind of scenario there. Anyway, so that's an interesting little tidbit for those of you that are in more rural areas, or those of you like me who hover between the suburbs and the big cities, and we kind of have access to both. All right, so this is a little bit more medically, but if you're interested in seeing what some national and provincial examples of administration of oxytocin, here are some things here. And that's why sometimes you'll hear doulas talk about how 20 is a max dose and sometimes 30 is a max dose. You can see that sometimes it goes up every 30 minutes, sometimes it goes up every 60 minutes. So we can see that there's some different things, and there's going to be variation from place to place, right? If you're interested in looking at what other countries are doing, or maybe you're coming to us from another country, here are some other things that you can look at as well that show us what's happening in some other countries, if that's interest to you. And if we're thinking about how often people are getting Pitocin in labor, what we can see here is that in Ontario, about 54% of all low-risk patients receive it at some point in their labor. That's a lot, isn't it? Right? Here we can see that some stats here, over 50% of all low-risk pregnant patients had an unassisted spontaneous delivery when given oxytocin. Okay? 19.4% required assisted vaginal birth. 25.9% of all patients who received oxytocin had an unplanned cesarean birth. All right, so here's some stats if that's of interest to you, and by level of hospital, which is always interesting to look at as well. If you want to learn a little bit more about litigation and the claims that we were talking about before that relate to induction augmentation by place of birth, right? So by the different level of hospital care. So here we can see these were the years 2008 to 2017. If that is of interest to you, that you can find that in here as well. All right, and then the report really dives in deeper into each of the points. Now, I really, really love this one on shared decision making, and I'm only going to look at the ones that relate most closely to our work as doulas. And I think this idea of shared decision making is just so foundational to all of the work that we do, and it really, really needs to be discussed in a lot more detail than we often see, right? And to all the care providers that are out there doing this work, just my heart goes out. I really have just so much respect for all of that work. What we're talking about here today is where there's a discrepancy, what's happening in the areas that we serve and these guidelines and recommendations, right? So again, the discussion must be documented by the ordering practitioner, and it talks a little bit about, being cognizant, recognizing the unique cultural and religious views, and sometimes clients aren't going to want to go along with a recommendation that a care provider makes because of some of those religious and cultural views, philosophical views. And that's a really important thing for us to be able to respect when we're providing care and we're providing truly informed, evidence-based support, in care and medicine. So poor communication was noted in 4% of the CMPA obstetrical cases and 8% of the HIROC cases. And I think that's something that we hear sometimes from clients is, I didn't know it was going to be all of these things. I didn't know that. No one told me that, right? And so it's important. If you go into this document here, and we're going to include the link to this document in the show notes, you can see here, there's some links in the appendix. Right? There's a pamphlet. You could share that with your clients. if they're looking for more information, helping them to facilitate that informed decision-making. Yeah, so oxytocin is start or advanced labor, and there's another one here in Appendix Q, okay? All right, so one of the things that I think comes up a lot for us as doulas is when our clients say, oh, hey, my care provider says that I should be induced for this reason. And maybe we know that that's not a common indication for an induction. And we find ourselves in a bit of a tricky spot where we don't want to diminish their confidence in their caregivers, but also we know that they don't want to have an induction, that there's a discrepancy here, right? There's a little bit of a gap between the two. And so here, number 3, remember that it should only be with appropriate indication. We should only be inducing people with appropriate indication. So what is that, right? What are those indications? So you can come here to Appendix I and J, and it helps to go through some of the things that we want to look at. So let's have a look at Appendix I. And this talks also a little about the Bishop score. Bishop score is an important thing for us to understand as doulas and for us to be able to talk about as well. Okay, so here we go. Appendix I is indications for induction, right? So high priority, of course, people with preeclampsia over 37 weeks, maternal disease not responding to treatment, hemorrhage, choreo, fetal compromise, preterm rupture of membranes with GBS, okay? Other indications, post dates. So over 41 completed weeks or over 42, what they consider, of course, post-term, right? Post dates over 41, post-term over 42. Uncomplicated twin pregnancy over 38. Diabetes. Specific, maternal or baby issues, IUGR, oligohydramnios, hypertension, prom, stillbirth. What are some contraindications? Right, contraindications. Breech, right? Abnormal fetal lie, of course. Placenta previa, or vasa previa, cord presentation, significant prior uterine surgery. So we're not talking about VBAC specifically there. Active herpes, pelvic structural deformities, previous uterine rupture, right? Unacceptable indications, unacceptable indications. Say it louder for the people in the back. Care provider convenience or patient convenience. Suspected fetal macrosomia. That, in other words, is called suspected big baby, okay? That is not an acceptable indication for labor. The number one reason that is given is shoulder dystocia, okay? Let's look at this again. There is no reduction in the incidence of shoulder dystocia, but twice the risk of cesarean. Right, folks? I think this is a really interesting read, isn't it? Now, if we look at the indications for augmentation of labor, okay, so a latent phase labor that exceeds 20 hours in a first time birthing person, or 14 hours in someone that's had a baby before. Right? Slow progressive labor defined as a dilation of less than 0.5 to 1 centimeter per hour during active labor. So not including early labor, right? Active labor, and we know that that's at least 4 or 5 centimeters beyond. An arrest of dilation that is more than 2 hours and that has inadequate uterine activity, right? And then the second stage, arrest of descent. So those are the reasons for augmentation. All right, so let's head on back now to see some of the other points in the article. So finally, the last point that we're going to look at, we're going to skip over all of those medical ones because they don't really have a lot to do with us, although you're welcome to go on and read through those if you'd like. Recommendation number 11, which is increasing patient labor support, right? And that's where having that one-on-one midwife or nursing care is really important. And of course, we know that this is where doulas can help to really round out the team by providing a lot of additional support. And what this tells us here and what they talk about is that although this doesn't necessarily improve perinatal outcomes, that it helps people to have a more enjoyable experience, it increases family satisfaction, right? And that the babies tend to have a better APGAR score. So all of those things are really, really important. And I think it's really amazing for that to factor in here, that people need to receive continuous support, advocacy, and monitoring. And I think this is where doulas, we can really help to support the team. Like I said, nurses and medical staff are so short-staffed and understaffed right now. This is such a wonderful opportunity to be part of the team. I hope that you found this useful. This just seems like so many interesting things coming up in these recommendations and these new guidelines. And I'm really excited to see how they get rolled out and implemented. I'd love to hear about what's going on in your community, in your area. And anything you want to share about this video, please remember to subscribe, and we'll see you again soon.